Good Bonjour, bon dia. I'm Dr. Mary Stephen. Welcome to the WHO Africa Media Briefing, which is taking place in collaboration with the APO Group. First, some housekeeping. We have interpretation in English, French, and Portuguese. Please go to the bottom right-hand corner of your screen, click on the globe icon, and select your most preferred language. François in French.
Bonjour à tous et merci de vous être connectés à ce briefing de WHO Afrique en collaboration avec IPO Group. Merci d'utiliser la fonction Q&A intégrée, questions et réponses intégrées à Zoom pour poser vos questions et vous pouvez choisir la langue dans laquelle vous souhaitez entendre la conférence avec l'outil d'interprétation qui est le globe dans votre barre d'outils. Merci à tous.
Merci, François. Joining us from Brazzaville, Congo, is Dr. Fiona Aterube, who is the new Vaccines Introduction Officer at the regional office here in Brazzaville. And then Dr. Fiona will introduce the remaining panelists. Over to you, Dr. Fiona.
Thank you very much, Mary. Good morning and good afternoon to all journalists joining us for this press briefing on COVID-19 and the vaccine rollout in Africa. I'm pleased to be joined by Ms. Joanna Admiro, who is the focal point for supplementary immunization activities at the Ministry of Health in Angola. She will tell us more about Angola's experience in rolling out multiple COVID-19 vaccines. The third wave of the COVID-19 pandemic in Africa is still raging at full force. After a slight dip in cases last week, COVID-19 cases are surging again, rising by 19% to nearly over 278,000 this last week. The latest data tells us that Africa is still on the crest of a third wave and still recording more cases than in any earlier peak. We cannot take anything for granted and we must stay fully committed to proven prevention measures. Tragically, deaths in Africa reached a record peak this week with over 6,400 deaths recorded. Over 172,000 deaths from COVID-19 have been recorded in Africa so far, and our hearts go out to everybody who has lost someone dear to them. Turning to COVID-19 vaccines, after a tough 3 months, we are seeing more positive prospects as vaccine shipments to Africa start picking up. The last 2 weeks of July saw a 12-fold increase in vaccine deliveries compared with the first half of the month. Nearly 12 million doses were delivered through COVAX to 24 countries in July. This is more than the volume received in April, May, and June combined, and bringing the total number of doses shipped to Africa so far to 91 million. We need to be clear though, in a continent of over 1.3 billion people, this is just a tiny drop in a very large ocean. And in the face of a surging third wave and more contagious variants, vaccine shortages leave Africa dangerously exposed. We have a very long way to go. With less than 2% of Africans fully vaccinated, we cannot get vaccines fast enough into the arms of the people. However, the efforts to scale up shipments are paying off. The current dose sharing by the United States government and European countries are expected to continue, and shipments from the United Kingdom will start soon. Countries will also be receiving new rounds of COVAX allocations in the coming weeks. Until the end of September, we expect around 110 million doses to be delivered to African countries through COVAX and the African Union. We do indeed commend the African Union's efforts and the message that we received this morning of the doses that they have secured to increase the number of people vaccinated on the African continent. Beyond September, as commitments by COVAX and the African Union and bilateral deals come through, we hope to meet the target of vaccinating 30% of Africans by the end of this year. But we also need up to 250 million more doses to complement the COVAX and African Union doses to meet this goal. In this new phase of vaccine delivery, many countries will receive more than one type of vaccine. batches with varying shelf life, as well as single and double dose vaccines, meaning that logistics of vaccine rollout will be more complex. It is important that countries set up vaccination strategies that will ensure doses are efficiently administered. At WHO, we are supporting governments to implement measures that will maximize the impact of COVID-19 vaccination, including simplifying the rollout at local levels, as well as minimizing wastage. We continue to work with countries to ensure that key aspects such as assessing their vaccination coverage, usage capacity, COVID-19 infection rates, as well as vaccine management are well anchored to successfully vaccinate their populations. As the vaccine pipeline grows, countries may see a surge in demand by the population. It is also possible that the demand could be low despite availability. As such, countries need to monitor and adjust their rollout strategies accordingly. Importantly, vaccine rollout plans should aim for a high uptake in priority population groups and provide equitable access for all populations to achieve high vaccination coverage. Africa is no stranger to mass vaccination campaigns. Although COVID-19 vaccination is an unprecedented drive that presents many challenges, the continent cannot continue lagging behind the rest of the world, to share the endeavor to save lives. I thank you once again for joining us, and we look forward to a discussion.
Thank you, Dr. Fiona. And now to you, Mrs. Joanna Admiro. Angola has received different types of COVID-19 vaccines. Can you tell us how your country is prioritizing and managing the rollout of these vaccines?
Bom dia a todos. Eu estou a ser ouvida?
Go ahead.
Estou a ser ouvida? Bom dia. Eu queria fazer uma introdução sobre a situação atual no país. A situação é estável, pensa embora com o registro de infecções.
Despite the fact there's been an increase in new infections in specific areas in the country, more specific in the provinces of Huambo, Cunene, and Huila. In terms of the capital, which was the epicenter of the epidemic at the beginning, is now more under control. So generally, the country has seen 43,158 cases, of which 2,150 are still active cases. Of these, about 88 new infections were recorded in the last 24 hours. We've got 128 deaths thus far, and we can see that there's been a strong level of recovery. So we've got 39,582 recoveries, of which 193 recoveries occurred in the last 24 hours. In terms of the vaccination process in our country, as you know, and as has been said before, Angola received its first doses of AstraZeneca in March. So we received 624,000 doses of AstraZeneca Oxford in March through the COVAX initiative. On the same day, we started to vaccinate our health workers. And up until today, we have already vaccinated 970,607 first doses. As a total, we have already vaccinated a total of about 94% of the vaccines that we have received. In terms of our vaccination campaign, we mobilized various high performance vaccination centers where they can vaccinate about 300 persons per day. And they've been vaccinating people from the armed forces, from the security services, from the health workers, amongst health workers and various ministries that are directly involved with the population. We've received AstraZeneca, Sputnik, Sinopharm, Sinovac, and other vaccines. We've received approximately 1,836,000 doses of vaccines. And we've already covered approximately 5.7% of our target population. We have some challenges. For example, we've got increasing demand for the vaccine and we've got a lack of sufficient vaccines. We also have some uncertainty regarding when we will receive more vaccines under the COVAX initiative. We also have to increase vaccination in certain provinces. We need to reach the more remote municipal areas as well. Because of the fact that there's a lot of population movement in the country, and therefore we need to vaccinate the people in the more remote areas. We also have a lack of important medical material. And we also need to access the 10 border posts that border on the DRC, Zambia, Namibia, and various others in order to ensure that we administer and roll out the vaccines in a joint way with those countries as well in order to cover those border posts. This is what I'd like to say initially. Thank you very much.
Obrigada, Ms. Joanna. Thank you very much. So now that you have heard from all our panelists, it is time to ask your questions. You can do this by using the Q&A function on the Zoom platform. And if you would like to go live, please indicate that by raising your hand. And remember to give us your name and the name of the media organization you represent. We have on hand Dr. Gilson Pala, who is a routine immunization and new vaccine introduction officer at the WHO Regional Office for Africa, and Dr. Fiona Braka, who is the program manager for emergency response here again at the regional office. They are on hand to answer your questions. So right now is your time to ask your question. Rhoda, are you ready to ask your question? See.
Hello, it's Paul Adepoju, and my mic is on, so I think I should.
Okay, we can take you first, Paul.
Yeah, so thank you very much. Today we heard a lot about Africa's the new Johnson & Johnson vaccine. So I would like to know what is being done by WHO, whether WHO is involved in any way in helping countries to quickly roll out these new sets of vaccines that they will be getting, and whether these plans are adequate enough now for Africa to get to its desired coverage. And I also have a question. I don't know whether the sequencing expert is on ground. We found out that the data from Africa, sequencing being done in African countries are really like getting too late, like several weeks behind, and we are not having a true picture of what is happening in real time. I don't know whether this is correct and what is being done to actually improve the turnaround time of Africa's sequencing capacity. And my last question is on Nigeria's third wave. Nigeria is a very big country, and it has been confirmed that the country is in a third wave now. So with its population size, what do you think Nigerian government can still do to quickly stem the spread of this pandemic? Thank you very much.
Thank you, Paul. The first part of the question, Dr. Fiona Aterube, if you can answer that, and then Dr. Fiona Braka to answer the second part of the question.
Thank you very much, Mary, and thank you, Paul, for that excellent question. Indeed, like I mentioned, we welcome the African Union's announcement this morning. We as WHO are a technical lead in this work in rolling out the COVID-19 vaccine on the continent. Our work actually does embrace all vaccines, irrespective of where they come from, irrespective of the source. So indeed, we supported countries to develop their national deployment and vaccination plans, which plans encompass all vaccines, again, irrespective of the type of vaccines. We do support countries in the planning and preparation for the vaccine rollout, in risk communication, in registering each vaccine and regulation of the vaccine in each country, and also in safety surveillance. It doesn't matter what vaccine it is, we support countries to ensure that they are ready to roll out whatever vaccine it is. So we were aware that these doses were coming. We're working very closely actually with the African Union and Africa CDC to plan for this rollout in countries. We're aware the vaccine doses were coming. Since we are working closely in contact with them, we knew that they were actually coming in August. We expected them end of July. We knew they were coming around this period of time. This is the time that we expect multiple products coming onto the continent. Most countries did not have Johnson & Johnson, but right now we've also put out a guidance and are supporting countries to be able to roll out these multiple products, including the Johnson & Johnson, which is the only single dose vaccine that we have so far approved for WHO emergency use listing. So indeed, we are supporting the countries irrespective of the source of vaccine.
Thank you, Dr. Ateube. Dr. Braka?
Thank you for the question on the efforts to improve on the genetic sequencing turnaround. I would like to inform that WHO, along with the Africa CDC, did start an initiative last year to try and support the region, the countries, in improving genetic sequencing capacities and genetic surveillance. And to date, 53 countries have so far submitted their information or benefited from this initiative, with over 31,000 samples that have been sequenced. So we are seeing over time improvement in the genetic sequencing capacities. As WHO, we are working with countries to improve their own capacities, those that have genetic sequencing capacities. And we do this through trainings and support for supplies to enable them to conduct these activities. We are also working in the Southern African region. We do have a lab set up there, working with partners and the South African government to support 16 countries in the Southern African region. And our plan is to scale this up to the western part of Africa and central part of Africa. So a lot is going on currently to improve the capacities in country and also subsequently improve the turnaround time for our results.
Thank you, Dr. Braka. There was a question on what Nigeria can do to improve their response on the third wave.
Yes, we are seeing a resurgence of cases in about 16 countries in Western Africa, including Nigeria. Over the past 7 weeks, we have seen an increase week on week in the number of cases in these countries, and an exponential increase in the last 3 weeks. So Nigeria, in addition to other countries in the bloc, are experiencing a resurgence. And really, the main drivers behind this are the spread of the Delta variant, which is highly transmissible, but also public health fatigue in meeting up with the public health measures that are recommended. Our advice to the country and other countries is that as much as possible, we have to continue the effort to improve on public health measures implementation. as we look at scaling up vaccine uptake. But in addition to that, also working on improving the capacities to manage critically ill patients with COVID, so stocking up on supplies for treatment of critically ill patients, and also oxygen production and availability, so that we are able to reduce the mortality for those that do contract COVID-19.
Thank you, Dr. Braka. So I'm going to ask the next question. This is from William from Bloomberg. Dr. Gilson, you can answer the question, and Dr. Terube can complement. What is WHO's opinion on the idea of people in wealthier, heavily vaccinated countries receiving booster shots before people in Africa receive any of these doses? Dr. Gilson and Dr. Terube can complement.
Ok, merci beaucoup pour la question.
Thank you very much for this question.
Ce qui se passe, c'est que
What is
il
happening
se
is
pose deux problèmes majeurs.
that we are faced with two
Il y a un
major
problème
issues here.
d'éthique,
First
et
of
c'est
all,
sur cette question que
there's
coule
an
un
ethics
problème
issue
technique.
and
Sur le
also a
plan
technical issue.
épidémiologique, on n'a pas
From an epidemiological point of
suffisamment de
view,
données
we do not
pour
have enough
déterminer
data
le
to
besoin
ascertain
de booster
the
et le moment où il
need
faut
for a
donner
booster.
le booster.
And at what
Alors,
point should a
il y a un
booster be
autre problème, c'est un
administered?
problème
There's
d'éthique.
another issue, which is an ethical issue
Si
again.
les 11 pays les plus
The 11
riches
countries, the richest
donnaient les
countries on the
boosters,
planet, if they
ils
are
auront
administering
besoin
boosters,
d'à peu près 800 millions de
they will
doses
need
de
800
vaccins.
million doses.
Alors que vous
800
savez qu'en
million.
Afrique, on a effectivement
Whereas you
besoin
know that in Africa,
de ces 8 millions de doses
we'll need
pour atteindre au moins 30% de
we will need this
population
8
d'ici
million doses
la
to
fin
reach
de
the
l'année
target of 30%
2021.
of people
Et dans ce
vaccinated
groupe
by the end of the year
est inclus les
2021.
personnes les plus
In this
vulnérables,
group, we have
à
included
savoir
those
les
that are most
personnes les plus
vulnerable,
âgées,
elderly
les personnes
people,
avec comorbidité. Et c'est dans ce
people
groupe
who have
qu'il y a le
comorbidities.
plus de décès.
And this is the group where we've noted a large number of
Or,
deaths.
l'objectif est de sauver des vies.
If the
Et
target is to save
l'objectif est
lives,
d'assurer la
if the
continuité de
objective
service.
is to
Et
have a
l'objectif
certain
est d'assurer
continuity
de
in services
rouvrir la société
provided.
et l'économie.
And
Donc, au lieu
if we want to
de
open up our countries and our economies,
mettre à la
instead
disposition des
of
pays les plus
making
riches les 800 millions de
available
doses,
to rich countries
nous
these 800
conseillons
million
de
doses,
mettre à la
we
disposition
would advise that
des pays africains ces 8 millions de doses
these
pour
doses
vacciner au moins
be made available for
30%
Africa
de
in order
population
to
pour
reach
sauver
the
des vies
objective once again, the
et assurer la
30%
continuité des services
and
et
save
aussi
lives and ensure services are
contribuer à la
provided
réouverture
and
de société et de l'économie.
enabling our
Merci.
countries to open up their economies. Thank you very much.
Merci beaucoup, Dr. Gilson. Dr. Terube, do you want to compliment, please?
Thank you very much, Mary. I just need to remind people that yesterday the WHO Director General, Dr. Tedros Ghebreyesus, actually called for a halt to these booster shots by wealthier countries until the poorer countries vaccinate their priority populations. So that is the stand of WHO, a call to a halt to these booster doses.
Thank you, Dr. Terube. The next question is coming to you, Mrs. Joanna. How is Angola rolling out the different types of vaccines to ensure that there is no wastage?
Well, once again, good morning. We adopted a strategy that allows for all people that are vaccinated to be registered. So once they receive the first dose, they are registered. And then for the second dose, they receive a message. It tells them when they need to come for their second dose. We are therefore able to manage who gets what type of vaccine. Currently, our vaccination sites have very large infrastructure, and in that infrastructure we have very different and large types of spaces, and we are able to provide 3 different types of vaccines in each of those sites. So when the people come to our site, they have already been registered by their institutions, or they do the pre-registration through an on-site registration, and that is the only way that they have got access to our vaccination sites. And in this way, we are able to ensure that we have sufficient human resources to provide the vaccine, and that we are able to rigorously control and monitor all our logistics based on the demand. Up until now, we haven't had any sort of problem. We've been able to satisfy the demand, and we've been able to manage this process. I hope I've answered your question.
Obrigada, Mrs. Joanna. Then to you, Dr. Atehube. Can you answer this question? What might explain the governor of Lagos' observation that 40% of people vaccinated in Lagos failed to return for their second dose? Is it the issue of hesitancy or the reputation of AstraZeneca vaccine?
That's an important question, because it is not uncommon that we have issues with loss to follow-up when it comes to vaccination. But for COVID-19 vaccine in particular, there's a difference between have failed to come back for their second dose or have not received their second dose. So why would people not have received their second dose? Because we had a lag. We know that we have had issues with these vaccine doses. So that could explain why we have had 40% of the people not yet received their second dose. Probably they've not, because for AstraZeneca, the schedule between the 2 doses is 8 to 12 weeks. So if the governor is counting anybody who got a first dose and is not registered as a second dose, we need to know, have they reached their 12-week mark for their second dose? And if not, if they have reached the 12-week mark, because that also reduces the number. But also we have issues such as communication. Indeed, hesitancy does come and exist in between, but we've not seen this as a major issue for all the information we have. For people who have received their first dose, we have not had hesitancy as an issue for them to come back for their second dose. There are usually many reasons why people would not come back for a second dose. Was there a change in vaccination sites? Was there a change in number of in availability of vaccine and access? So which was very common with the COVID-19 vaccine. So there's a lot that needs to be investigated. We've not had the issue of hesitancy from people who have had their first dose. We've not had it documented anywhere. And also issues with AstraZeneca, these were cleared, and now we no longer have populations having issues with AstraZeneca as a brand in particular.
Thank you, Dr. Fiona. Dr. Bracker, this question is coming to you. Can you provide an assessment of the impact of it on this pandemic? Also in Senegal, as in other several African countries, observation on the ground seem to point that there is a serious discrepancy between the reported cases and deaths and then the actual situation on ground. Can you also update on how wide you think this gap may be? With the latest surge on the continent, has the gap gotten worse? Did you identify new reasons for this discrepancy? This question is coming from Lauren from Agence France. Dr. Braca, please.
Thank you for that question. Indeed, we have seen an increase in the number of new cases in Northern Africa and West Africa, and more so a stabilization in Southern Africa, in Central and Eastern Africa. And we do know that the recent Eid festivities, yes, there were mass gatherings and social interactions. And it is likely that these could also have fueled the increase in the number of cases that we have seen in Western Africa and parts of Northern Africa, because we do have a large Muslim community there. In addition to the other factors, as mentioned, around the increasing transmission of the Delta variant. To the question on the discrepancies in the numbers of cases that are reported in Senegal and several other countries, we recognize that with the current testing strategy, we are not able to do mass testing for everybody. And so infections that are mild or asymptomatic may go undetected. So the numbers that we see are an underestimate of the actual burden. And so we do know that we are not able to test everybody. And so what we have is based on the numbers that we have been able to test. And we know that that's not a true reflection. So we recognize that. And as we look at these numbers across the countries, we do know that there is need to ensure that as much as possible that we prevent spread of the virus using the measures that we know of, because it's likely that the asymptomatic cases could be out there that we do not know of.
Thank you, Dr. Braca. And to you, Dr. Fiona. Please, can you answer this question from Matthias from Germany? Do you know if and where COVID vaccine productions are planned for in Africa? Wouldn't it be helpful to have facilities in Africa that will produce for the continent?
Indeed, it would be a dream for Africa to have vaccine manufacturing on the continent. So far, we've had a number of countries that have signed deals for the fill and finish. We had Senegal as one of the first countries in the region that has been producing the yellow fever vaccine at the Institut Pasteur. And recently, Senegal signed a deal at Still Institut Pasteur with Universals to manufacture the COVID-19, still again for the finish and fill for the COVID-19 vaccine starting mid-2022. We know that South Africa is already doing the fill and finish for the Johnson & Johnson, which is such a big thing for us. And these vaccines that will be finished and filled in South Africa will be used only in Africa. So that shows you that we have started and we have the capability for this. And South Africa is also starting a knowledge transfer hub to help increase this manufacture. Egypt is also having some of the aspects of the vaccine manufacturing and has mentioned that they will release their first 1 million doses of Sinovac. This is the one of the China vaccines in the coming few months for their population to use. Actually, I think they should have started even in August. So we also do have Morocco, which is a country that is also going to do the finish and fill. So there is capacity on the continent. What we need now is actually technological transfer. We are able to manufacture the vaccines, but not from scratch. We need more technology transfer, and the wave of the TRIPS that was given, and we're able to do that. So we have Senegal, we have South Africa, Morocco, and Egypt that have this capability.
Thank you, Dr. Fiona. Lisa from VOA, do you want to ask your question live? Lisa, are you there? Okay, let me read out her question. Vaccines have expired in some countries and become useless because of vaccine hesitancy and other reasons. What strategies do you have to prevent this happening? Dr. Gilson, please.
Merci beaucoup pour cette question.
Thank you very much for this question. Presently, the strategy that we are recommending to countries is to firstly organize reviews, interaction reviews. And with these type of reviews, all stakeholders at the national, local, and regional level can work together to identify what are the reasons explaining the vaccine hesitancy or the very low uptake. So there's vaccine hesitancy within communities at large, and collectively find remedial strategies. Once we've identified those remedial strategies, they can update the vaccination plan and the rollout to show how they can counter these hesitancies in the activities to come. So all these remedial measures to enhance uptake and increase demand for vaccine will take place. One of the other reasons that has been cited is the lack of fund for operational costs. So we need to advocate so that costs or funds for all components, including communication component and to fight against hesitancy, these means should be made available to countries in order to support the implementation of remedial measures that will have been defined through these interaction reviews, and the remedial measures will be a part of the vaccination plan for the next phases. So for now, in brief, we need to identify the reasons, and they're different from one country to the other, determine remedial measures, and finally, make resources available to countries to implement the remedial measures, which will enhance the demand for the vaccines. Thank you very much.
Thank you, Dr. Gilson. And the next question is coming to Mrs. Joanna. There is a lot of misinformation about COVID-19 vaccination. How is Angola dealing with this misinformation, and how are you engaging the communities to make sure that everyone is vaccinated? Mrs. Joanna, please.
Hello, thank you very much. In principle, when we received the first AstraZeneca vaccines, there were a lot of rumors that were spread around. Both on the social networks and between people themselves. But we know that whenever a new vaccine comes up, whether it's a routine vaccine or not, whenever a new vaccine starts to be used, we know that the communities also always raise queries, and there's a lot of misinformation coming out of that. So we try to meet with communities, carry out information campaigns, publicity campaigns, and try to work with influential people in the communities to correct the false information and the misinformation that the communities have received. When in Angola's case, we didn't have a problem with a vaccine hesitancy. It came to a stage where we actually didn't have enough vaccines to satisfy the demand. So we managed to overcome those rumors, that misinformation. We did a lot of mobilization, starting from the president himself, as well as ministers that spoke about the advantages of being vaccinated, and all those are very credible figures. And especially after the president actually took the vaccine himself, and there we saw many people, a huge increase in demand for vaccination. And so not only one type of vaccine, but all of them. Unfortunately, we couldn't vaccinate everybody because we have identified the priority group, which are the frontline workers. And those are, for example, those in quarantine areas, those that work in COVID treatment institutions, people with comorbidities, the aged. So we had to apply certain restrictions, and at the time, not everybody was entitled to be vaccinated. Our problem at the moment is vaccine insufficiency because we still have aged people who haven't received the vaccine. And sometimes some of them have to cover more than 40 kilometers to be vaccinated. So which that seems to be the situation in Africa, as we've already heard. But now you're hearing about Angola's situation in particular. Thank you.
Thank you very much, Mrs. Joanna. Dr. Fiona, please, can you weigh in on this question? How is the regional office tackling the issue of misinformation across the region?
Thank you indeed, Mary. Because of this vaccine, like Ms. Admira mentioned, coming with a lot of hesitancy, not just this vaccine, but COVID vaccine in particular has been special in a way. So WHO anticipated this, and we put out a whole infodemic response team, which is called the Africa Infodemic Response Alliance, which is a consortium of several partners that come together, and we do media hearing, listen to all the infodemic out there, all the questions that people have, and come up with answers to these questions. We've put up a whole site on viral facts, and we ensure that this information is answering the questions and the misinformation that is out there in the public. So we have the Africa Infodemic Response Alliance, we have the viral facts, and we do these press briefings just for that reason, also to counter misinformation also, and to provide the right information to the media and to journalists that are the people who have the credit, who are part of the credible source of information. We do media training also for spokespersons in countries, for opinion leaders. We have done a lot of things that we do in the background to ensure that we put out the right information in the easiest way possible for community members to understand.
Thank you, Dr. Fiona. Indeed, misinformation is a challenge against this COVID-19 fight. I'm going to pose the next question to you. Again, this is a question from Rhoda from BBC. With COVAX now relying on vaccine donations from rich countries, and these vaccines have a short shelf life, will the WHO give a time period of how many weeks left to the expiry date for countries to donate their vaccines? For example, Kenya says it only accepts vaccines with minimum 8 weeks before expiry. Dr. Fiona and Dr. Gilson can complement if there is addition.
One thing I need to mention is that there is a lot that happens behind the scenes before these doses get into countries. So indeed, one of the agreements we have had with countries and one of the issues we have brought to the table with countries that are donating doses is the issue of expiry, that the time between the vaccines arriving in countries and the time that they will expire, which we call the shelf life. So we have asked indeed that we have not less than 2 months expiry, but also before we receive these donations, we ensure that the allocation does not come randomly. We go through a whole allocation process as COVAX. The partners sit down and agree on which country we think is able to utilize, for example, the short shelf life vaccines, given the previous absorption capacity and rate of utilization of the vaccines they've received. And also we have had agreements, for example, with Johnson & Johnson, with the manufacturer in the US FDA, between COVAX and the US, to ensure that the doses that are coming to Africa are having all through the COVAX facility, the Johnson & Johnson doses have a longer shelf life than the doses, for example, they're using in the US. This is the same with the doses that are coming through the African Union. We do those negotiations and those technical discussions with the manufacturers and donor countries. And indeed, much as COVAX is relying on donations, is not solely relying on donations. We are having new advanced purchase agreements with several manufacturers, and COVAX shipments and procurement doses outside the donations are also coming in. Indeed, we do have these discussions before then. UNICEF, who does the movement of these doses, is also on the table to have these discussions. They made it very clear that they are able to move doses from, for example, one country to another when they have at least 6 weeks of expiry. So all that is put into context, and we ensure that the country that will receive any particular dose, any particular shipment, is able to use these vaccines before their time of expiry. And as Dr. Paluku mentioned, we have prepared the countries so that as soon as the vaccines arrive, they are able to roll them out.
Okay, thank you, Dr. Fiona. Dr. Gilson, I'll add a question, and then if you have something to complement on the questions just answered, you can answer together. A recent AU survey of 15 African countries shows that skepticism about the COVID vaccine remains high in many countries. If some African countries don't achieve their immunization targets, will COVID-19 become endemic in those countries? What consequence would this have for the real continent and the world at large? This question is from Christine from Dutch Press. Dr. Gilson, please.
Merci beaucoup pour cette...
Thank you very much for asking this question, to see if the demand does not increase, the disease will spread, and what we'll have is a situation with high number of deaths, hospitalizations, and this is not a good thing. That would be a first direct consequence. And another consequence, the fact that the virus will spread for a long time, it will mutate into new variants. And this poses a risk. The new variants could not be treated by the vaccines that are available and on the market, which could compromise all the work that has been done by other countries and in vaccination. So vaccination is an individual responsibility, a community responsibility, and also a global responsibility. And this is why all the measures should be implemented to be able to fight against this misinformation, these rumors, this false information against vaccination. We need to be able to fight and fight this misinformation for the population to take the vaccines. And if they do take the vaccine, we'll avoid hospitalization, we'll save lives, and we'll be able to reduce the possibility for the virus to develop into new variants. If we increase coverage, we can therefore contribute to free up our societies and our economies. So this is, in brief, the risks that we have if the demand increase doesn't happen. Thank you.
Thank you, Dr. Gilson. The next question is to you, Dr. Braka. This question is coming from Lucas. Is there a lack of oxygen, or will there be lack of oxygen in the next few weeks in countries in Africa?
Thank you, Lucas. Oxygen is part of the recommended components of case management for severe or critically ill COVID-19 patients. And with the increase in the number of COVID-19 cases that we have seen with the resurgence in the third wave, we have seen that the demand for oxygen at the moment is estimated as 50% more than we needed at this time last year. So the demand has certainly gone up with the rise in cases. And the barriers really are around the availability of adequate numbers of oxygen cylinders, the functionality and maintenance of oxygen production plants, and the skills, the personnel skills to manage the use of oxygen or to manage the oxygen plants. So WHO has been working with the countries to scale up the availability of medical oxygen during this pandemic. And we have provided oxygen cylinders, supported countries in resurgence, such as Rwanda, Liberia, Uganda, to procure oxygen cylinders. We have also supported some countries to revive their oxygen plants, such as Kenya, South Sudan, and DRC. And we're also providing capacity building in countries to improve the facilities, improve the capacity to maintain the oxygen plants and also to administer. And we have seen marked improvement in terms of oxygen availability in the region. Looking back, we had 68 oxygen producing plants at the beginning of the pandemic in the region, and we now have over 100. And we've also seen marked increase in the number of oxygen concentrators and the availability of oxygen cylinders. However, we do know that this is an area that still remains a critical gap, the availability of oxygen cylinders and the accessories in order to meet the demand. So we still need to scale up the production and the availability of these items, especially as we're seeing a resurgence in a number of countries.
Thank you very much, Dr. Braka. And then to you, Dr. Fiona, this question is from Naftali from Genoa. He's also asking to shed light on vaccine hesitancy in Africa. Again, what is being done to minimize it, and which demographics, age, gender, geographical groups are worst affected by the vaccine hesitancy on the continent.
Thank you very much, Mary, and thank you, Naftali, for that question. So from the studies that have been done, generally we know and we have seen the biggest demographics that are the people who are having the highest hesitancy or who spread the hesitancy are people who use social media. And social media, especially, we've also seen that it is the literate people, the literate, the so-called the intellectuals. So someone has coined the people who coined the COVID idea around that. So it is the people who are actually literate, people are able to read and pass on these videos and information that have been seen to have the highest level of hesitancy. But we have also seen that Central and West Africa had higher levels of hesitancy compared to Eastern and Southern Africa. It is the middle-aged and youth that show higher levels of hesitancy. So there is people who spread the misinformation, but there are people who are the priority groups that we have. So we ended up having healthcare workers, a part of the healthcare workers that did not understand the vaccine show hesitancy at the beginning. But with the current third wave that hit Africa, we've seen hesitancy levels really, really drop, because people have understood that indeed this pandemic does exist, unlike the other last two waves, where people still did not believe that this disease is very difficult. But also when they saw the Western world vaccinate higher numbers and more or less return to normal life, we have seen the hesitancy reduce. So again, people who use social media, who are the middle-aged and educated people, are the ones that have been seen to have the highest levels of hesitancy.
Thank you, Dr. Fiona. And again to you, what is WHO's position on vaccine passports and EU digital green certificates? So this question would be best suited for Dr. Braca in the international health regulation area. But WHO's position is that for now, we do not need these vaccine passports because of the difference in equity, in the inequities in access to these vaccines. Africa, for example, and other low-income countries have vaccinated really just a drop in the ocean of their populations, while the higher income countries have vaccinated. We have countries that have vaccinated up to 80% of their populations or even more. So we cannot compare these two situations, and WHO's position now is to at least for now to have a halt to these vaccine passports, not to be a requirement for travel. Countries can make those decisions, but they are not a requirement for travel right now. And we have also seen that the European Union countries that had put this green pass for freedom of movement within their countries and left out some vaccines have changed their status, and we now have free movement also accepted, and from other vaccine people who have used vaccines that were not listed under the vaccines that were allowed. But again, WHO's stand still remains very clear until we all have equitable supply and enough doses to cover the whole population globally. Thank you, Dr. Fiona. Indeed, this is very good news for international travelers. Dr. Braca, do you want to weigh in on this?
Yes, just to buttress what has been said, the International Health Regulations Committee, they are sitting in April, did recommend that to state parties that we do not need to have this proof of vaccination as a requirement for entry into countries, especially in view of the growing evidence that we are still building up on the vaccines, but also the gross inequities in terms of availability of vaccines across the regions. And so based on that, WHO does also have a position paper on this. We do not recommend this as guided by the IHR committee. And we are encouraging that more effort should be made to try and scale up the availability of vaccines to protect especially the high-risk groups across the world, as opposed to restricting travel across regions because of use of certain types of vaccines.
Thank you, Dr. Braka. We are now coming to the end of this press briefing. Let's turn to our two panelists. I will start with Mrs. Joanna and then Dr. Fiona to give us your final words. 1 minute each, please.
Começando por mim, primeiro agradecer por fazer.
Well, first of all, on my own behalf, I'd like to thank you for the fact that I could participate in this panel. It was very good for us to be able to communicate to you the realities that we're living in Angola at the moment. And I would like to urge everyone that we do everything that is possible and that we transmit to the wealthier countries the message that they mustn't forget Africa. We need to vaccinate our people. We want to vaccinate our people because the number of infections is increasing and we need those vaccines. Thank you.
Obrigada. And to you, Dr. Fiona.
Thank you again very much, Dr. Stephen, and to our listeners again, thank you for joining us. The third wave in Africa is real and it is raging, and we are seeing some of the countries even getting to their fourth wave. So we are not there yet. We are receiving much more vaccine doses in the coming few weeks and days, multiple products from multiple sources, limited quantities of each product. We need to ensure that we do the right community engagement and communication to ensure that we have these vaccines get into the arms of people. Yes, we shall get the doses. We have gotten the doses, but this is very different from getting these doses to the arms of the people who need them. So in order for us to prevent another catastrophe that we have seen from the previous waves, let's ensure that we spread the right information, people get vaccinated, but also ensure that we keep using the proven prevention measures of sanitizing or washing hands, social distancing, and ensuring that we are not part of the crowds and keeping in our homes and only move when we need to. Stay safe, and thanks again for joining us.
Thank you very much, Dr. Aterube. Thank you very much. And I'm sorry for coming back to you. There was a last burning question from Esther. If you could just take 1 minute to answer and then we round up. Is the increase in price of Pfizer and Moderna in the Western market going to affect Africa in any way? And will those donor countries donate those vaccines if they are expensive, or we are doomed to get donations of the cheap ones? 1 minute only.
Thank you very much. We need to note that, for example, the US government, the donated doses that we are receiving have already been purchased, some of them that are coming directly to countries. But on the other hand, we have, for example, the US government or the European Union governments that purchase their doses through the COVAX facility. The COVAX facility has negotiated prices, so it is much easier and cheaper for us to purchase through the COVAX facility, the procurement to go through the COVAX facility. So the donors have noted this and are going through the COVAX facility to ensure that we get the right prices. And no, we are not doomed because the doses have already been given to us, even with the prices, the price tags that they bear.
Excellent. Thank you very much. So I would like to use this opportunity to thank our panelists and to also Dr. Braka and Dr. Gilson for stepping up to answer questions. Thank you to all journalists for the good work you're doing in making sure that the general population gets the right information. We will bring the press briefing for today to an end and hope to see you next week. Thank you and have a nice day.
Thank you.